Our next speaker is Dr. Bob Zeman. Bob is the chair of the Department of Radiology and Radiation Oncology at the George Washington University Medical Center right here in Washington, D.C. Bob chairs our wide-flung carrier advisory network, and he is our commission expert on coverage issues. He's a little under the weather today, and I think that's not just because of all the toxic Medicare policies he gets exposed to on a daily basis. But thank you, Bob.
Yeah, I do apologize for my laryngitis, but hopefully I'll be able to get through the next 10 minutes. So I do want to talk about the activities of the Carrier Advisory Committee and some other Medicare-related activities. And I'd like to start out by thanking these individuals, particularly Anita McLaughlin from the Economics and Health Policy Division, who really helps us. Her, along with all the CAC members from all 50 states, really do the heavy lifting for the Carrier Advisory Committee. I have no financial disclosures to make, but I am a voting member of the MedCAC, and when I do the ethics training for the federal government as an unpaid employee, they do remind me that I am a government employee. So I do want to say I'm speaking on behalf of myself today, not on behalf of CMS or the MedCAC panel. Obviously, we're going to have to get all of our ducks in a row going forward in the future. You're going to hear a lot about value. You're going to hear a lot about alternative payment models at this meeting. But certainly, CPT codes for coverage, development of these local coverage determination or LCD policies and national coverage determination is still going to be an ongoing issue that we really need to address. And we do need to be prepared for more and more audits in the future. So we'll talk about those two topics predominantly. You've heard a lot this year and prior years at this meeting about the coverage and payment cascade. Obviously, you need CPT codes, and those need to be valued before you can get to coverage. But ultimately, once that happens, then CMS will weigh in on whether coverage is going to be granted or not. Now, if it's a screening procedure, there's a stopover here for the USPSTF, congressionally mandated to evaluate screening procedures for the Medicare program, and that's why they've become involved in CT colonography as well as mammography decisions. By the way, as far as CTC goes, we are expecting a reevaluation by the USPSTF later this year, and hopefully we'll be able to move forward after that with Medicare. So this is really the space we live in terms of coverage, the LCD and NCD space. LCDs obviously are developed by the MACs, or the Medicare Administrative Contractors around the country, with input from the carrier advisory committees in those jurisdictions. NCDs, on the other hand, are developed by the federal government at a national level, and again, coverage may be achieved by either of those mechanisms and development of policies. Most advanced imaging, cross-sectional imaging particularly, is covered under the LCD approach, and that's surprising to a lot of people that we don't have so many national policies as we have regional or jurisdictional based policies. This is a map of the 15 MACs throughout the country who develop LCDs, and this is going to consolidate down to 10 MACs in 2016. So there's a move afoot to move to less and less of these MACs around the country. We worry that maybe that'll decrease our face time with medical directors of the various MACs, but that's something we're going to have to deal with going forward. A lot of you have seen these types of local coverage determination policies. The focus here is on ICD-9 codes, soon to be ICD-10 codes. But nevertheless, the codes in most of these policies are listed, which are the payable indications for a lot of the studies that we do. So this is a very important policy. And if any of your chapters don't have CAC representatives working from the chapter and integrating with our CAC network, I would urge you to encourage one of your members to become involved in that way. Now, the LCDs are based on a reasonable and necessary criteria, and so are the NCDs, or the national coverage determinations. Again, for an NCD, you want a procedure to be reasonable and necessary for the diagnosis or treatment of an illness or injury, and these NCDs are generally made up directly by CMS, but occasionally they will, and it's an evidence-based process, but occasionally they will involve the MedCAC, or the Medicare Coverage and Advisory Committee, which consists of a panel of 15 experts, particularly in health policy, who will make an advisory decision for CMS, and then CMS ultimately will make the decision based on that input from the MedCAC. So when it comes to NCDs that are in evolution, there are quite a few actually that are being currently considered in various phases of proposed resolution by CMS. Obviously on CT colonography, we're awaiting re-review by the U.S. Preventative Services Task Force. For PET-CT, in the context of non-FDG or non-sodium fluoride oncologic imaging, CMS has proposed that after an agent is approved by the FDA as safe and effective, that they would allow development of LCDs at the MAC level, essentially for coverage to be granted, and that's a proposed NCD that has come out. With regards to FDG for oncologic applications, the good news was that CMS has proposed lifting the coverage with evidence development restriction so that we don't have to continue for subsequent evaluation reporting these cases to NOPR, to the National Oncologic PET Registry. That's a good thing. They did, however, propose continuing the restriction on subsequent evaluation of prostate cancer. And what was particularly disturbing is they proposed limiting the subsequent evaluation to one lifetime scan for that patient, or one post-treatment scan. And again, we think that's a very bad idea. The ACR as well as the SNMMI reacted to that in a very detailed letter about the need to have more subsequent evaluation scans be allowable, even if that's at the MAC level. But again, we thought that restriction was unfortunate and not a good choice. We haven't heard yet anything about beta amyloid detection. As you know, there was a MedCAC panel hearing about that, of which I was a member, actually. And we're awaiting the proposed decision, although the MedCAC voted relatively low score in terms of its confidence that beta amyloid detection would affect health outcomes, because again, we're dealing with a disease, and Alzheimer's disease, that really doesn't have an effective treatment. So it's very difficult to show a change in health outcomes. And again, we're waiting on some decisions on carotid stenting, as well as better defining the role of coverage of evidence development in the future. Again, CED is something that we saw in the context of PET and with the National Oncologic PET Registry, but CED is used in other non-radiologic areas also. And in fact, there are some guidelines that are now coming out about the evidentiary standards, about rules about Medicare population generalizability that'll help in the future in order to use CED. Well, last area I want to touch on is audits. And audits are just going to increasingly become a way of life. The three audits that most commonly target physician billing activities are the CERT, or the Comprehensive Error Rate Testing audits, the MAC audits, the Medicare Administrative Contractor Review audits, and the RAC, or the RA Recovery audits. One thing I want to show you is that if you go to the Medicare website and look under CMS Data Navigator, you'll see all these reports, many of which are anonymized. Some are restricted just to the federal government and are not anonymized. But look at all the data that can be mined using your claims data. There's ones, basically I just scrolled through the page and it just kept going and going. And essentially, I think we really do have to be ready for extreme data mining in the future. Again, we don't want to be at the end of the bell-shaped curve or an outlier in terms of how we bill. And as this screenshot from the movie version of 1984 shows, Big Brother really is watching, because electronic medical records don't provide better coordination of care only, they also provide the ability to data mine. And I think we need to be aware of that. The CERT audits have been around for a long time, the Comprehensive Error Rate Testing audits, and these are not targeted reviews. They're more general reviews to try and get at an error rate for claims submission so that these can be reported within CMS and to Congress. And generally, this 10.5% number, which you see down here, is the number that's often quoted as the error rate for submitted claims. If you do get a request for one of these audits, failure to respond constitutes an error, as does insufficient documentation or coding errors or lack of medical necessity. Again, it is important to pay attention to these because overpayments are recouped, but underpayments are also paid under these non-targeted reviews. MAC reviews, on the other hand, have really become much more prevalent in the last few years. These are targeted reviews where the Medicare Administrative Contractor will come after a practice and usually start with some post-pay review to look for the adequacy of your coding. If there's an improper payment, they will proceed very often with not only recouping those funds, but actually putting you on a prepayment review. And if you're under a prepayment review, a lot of claims are going to be held while they're reviewed. It's really going to affect your days in AR. So again, it's important to take these things seriously and respond with information. Again, the adequacy of documentation is a real focus of a lot of these reviews, and although the focus is supposedly educational in nature, again, you may be subject to recovery efforts if in fact claims were submitted incorrectly and with errors. One of the things that's come up out of these types of reviews from our CAC members is the realization that, again, we have to be able to provide documentation, ours as well as that of the referral source potentially. That may mean the hospital, or it may mean referring physician office notes. And this has become a very contentious issue, obviously, because we don't always have access to that information. But the MACs have consistently held that to be the case. And then finally, RAC audits are, again, one of the more controversial types of audits. These are targeted reviews, and one of the reasons they're controversial is because the RAC is paid a percentage of the recovered payment. So they have all this upside potential, but if they make mistakes in the audit or do audits unfairly, there's no real penalty or downside to them, and that's something that greatly concerns us. There's a limitation on the number of records, a tight timeline on the appeal process, and there are multiple levels of rebuttal that are available to you. If you go to the cms.gov/RAC website, it'll actually list the RAC auditors for the country. There's 4 of them that do the auditing, and these are their web addresses. I won't leave that up there very long, but essentially if you go to that CMS website, it has information about all of the RAC auditors. The RAC audit program obviously has some troubling elements to it, and in fact CMS felt the need to actually post this site called Audit Program Myths out there to try to dispel some of the rumors. But a lot of the rumors are truth. And we've heard from a lot of our CAC members about this, and this prompted, fortunately, a meeting that occurred with the GAO between the RBMA and the ACR, and the GAO was very receptive and wanted to listen to all of the examples of bad auditing practices that we were able to bring forward, including a lack of coordination, flawed methodology, lack of transparency on details of the issues and processes, and the huge burden this has on practices. And so we did bring that forward to them. Well, I want to end there. This is my version of the Dr. Ellenbogen glass half full or half empty, but I think if you focus here on the left-hand part of the slide, there's no question that fee-for-service will still exist to some extent under the Affordable Care Act and for quite a few years into the future, and we have to be familiar with the coverage paradigm and getting coverage for our new procedures. I don't think the USPSTF and death panels will take over the world, but I think a lot of the serious lifting that we still have to do is on the left-hand side of the slide. And obviously, we still need to develop new technology and grow, because it's safer to search in the maze than remain in a cheeseless situation, which was our theme in the section a few years ago, and we need to develop new technologies. So thank you very much.